today because I've got just a minute after 7:30. But with that, I'm going to go ahead and turn it over to Dr. Sarah Rowan.
Good morning, everyone. Thank you for joining us this morning. So just to set the stage, in response to the COVID-19 epidemic, we have started this bi-weekly COVID-19 learning series. This is for the Mountain States to discuss COVID-19 management issues in our region, and we welcome all comers to this session. So this is session 3 today. We encourage you all to forward the link for the registration to your colleagues if you know anyone else who might be interested in joining this. Today, our speakers will be covering surge planning, and just a little background. My team is out testing in community locations, and on Saturday, we tested 317 people and over 70 people tested positive. So I think surge planning is really, really timely, and I'm looking forward to these presentations. Our topics change every 2 weeks. They change with every session, so please tune in and stay tuned. We have tried to be very responsive to the needs of the epidemic with our agenda and our topics for this series. So you're welcome to suggest future topics to that point, and you could send them through the evaluation or send a message to Victoria or Caroline. We strongly encourage you to submit questions. Either you are welcome to just hang on to them and say them during the Q&A, but if you'd like to put them in the chat box as you're thinking of them during the presentations, that would be terrific too. We want to encourage everyone to ask questions and have an open dialogue here about these topics. So before we get started, I want to acknowledge that this ECHO series is presented as a joint collaboration between the National Emerging Special Pathogens Training and Education Center, NETEC, Denver Health, the Denver Prevention Training Center, and the Robert Wood Johnson Foundation, and Project ECHO, which was first developed in New Mexico. My name is Sarah Rowan, and I'm an infectious disease doctor at Denver Public Health, and I'll be one of the facilitators for this series. So I'm going to turn it over to Victoria. We'll do a tech check. We'll have 2 short presentations, and then we will have Q&A and panel discussion.
Thank you, Sarah. So as always, we will be recording the session and uploading it to our resource library, and I'll put the link for that in the chat in just a moment. But I just want to prompt you all now, as Sarah mentioned, today's session is on surge planning. So I'm going to call on a few people in a couple minutes to kind of hear about what you're hoping to take away from today's session. So as always, we have our chat function. So if everyone could put in the chat where you're calling in from. I just put in there that I'm calling in from Inglewood, Colorado. You have the mute and unmute button, which is again down in your lower left. So when you're not talking, if we could have you stay muted, and when you want to talk, you can go ahead and click unmute. Next to that, you have either stop video or start video. We would love everybody to go ahead and hit start video if you are not. That makes it much more interactive for everyone, including our speakers and our panelists that are here today. At the top, you can change your view from being the speaker view to the gallery view. That's going to be up in the very top right corner, and it'll say view. And then once you click that, you'll get a drop down depending on your Zoom version. But so as I mentioned, we are going to go over surge planning. So I maybe tricked you all into knowing who's paying attention and who's not, but we have a few people in the chat who put in where they're from. So I'm going to just pick a few people since I know you're by your computer, just to kind of hear about what you want to take away for today's session on surge planning. So Beth Felty, if you could unmute and let us know what you're hoping to take away from today.
Good morning.
Good morning.
Well, as a critical access hospital, I am hoping to learn, some of the other resources that we might have in this area and region. Right now, several counties in the Southwest region rely on Mercy to take those critical care patients. since we don't have an ICU.
Awesome. Thank you, Beth. Well, hopefully we can figure out if we've got some extra resources in your area for you. Next, let's go ahead and call on Marianne DeGroat.
Oh, I've got my dogs.
Me too.
Knowledge, and especially with the influenza epidemic, I see ID patients in the hospital. I also am getting ready to attend my mother's funeral and out of state. So any lessons about, indoor protections and things like that.
Great. Thank you, Marianne. And how about one more? Let's go with Amy Meditz. I may have said that wrong.
Hey, this is Amy Meditz. I think one of the critical pieces that we're very worried about is our employees and being able to keep them separated during break times during this weather changes, and that contributing to the surge itself, these inability to separate themselves during eating. And I'm interested in other people's solutions to helping our staff accomplish that.
Awesome. Thank you, Amy. Okay, then I'm going to go ahead and turn it back over to Sarah, who is going to introduce our experts of the day.
Okay, thanks, Victoria. Thank you to the people who got randomly called on. Two of them are, I know, Amy and Marianne. Hello, and Beth, I love your town. So hang in there. So first I'm going to introduce Marisha Burden, and she is an associate professor of medicine and division head of hospital medicine at University of Colorado. And she will talk about surge planning from a university perspective. And Marisha, you can go ahead and share your screen when you're ready.
Okay. Great. Can you guys hopefully see it? Yep. Great. All right. Thank you, Sarah and Victoria. True pleasure to be here. So thank you for the invitation. So I hope to go over in the next 10 minutes or so, harnessing the power of hospitalists in operational disaster planning. It's a much bigger effort than just hospitalists, as you will see. I thought I would start with a lovely quote from Rutger Bregman. I'm reading his book, Humankind, which is a pretty amazing book. But he's known for being quoted as saying or talking about the setting of disasters. And he highlights that when looking at over 700 different case studies, when you look at how people act or behave in the times of crises, that especially in the times of crises, we get to show our best selves. And it's an opportunity, I think, to take a deep look at the status quo and to not only become our best selves, but to hopefully harness the power of our health systems to be even better as well. In the past 8 or 9 months, it's been a wild ride. I'm sure you guys have all been on that ride with us. And 3 key things that I hope to highlight, kind of infused throughout the next 10 minutes, that we've thought about a lot and worked on a lot. Which is one around a framework for capacity management and growth, extreme growth if needed. How do you bring in net new people into the system to help you care for this large number of patients with the same level of knowledge and working ability to take care of patients who have COVID? And then talking about adaptations to care that we've seen both locally and nationally to help us do all of these things. Before I get too far, I just want to highlight the clinical operations team of my division, and specifically Casey Bowden and Adam Meyer on the call, and happy to answer questions along with me later. But a huge shout out to all these people, because everything I'm about to present is not just my work, it is a whole team's effort of many, many people. So I remember about 8 or 9 months ago when Casey and me and Julia Limes were sitting in a conference room thinking about how we were going to manage a disaster in such a way that we had never experienced before. We had plenty of plans in place for a day or two of a disaster to manage that, but we had to fundamentally change the way we were thinking about the next many months to come. And Casey actually helped to come up with this framework that we call the 4C with 4 highlights that I'll just really quickly go over that you'll see as we go through each of the things that we've done at our hospital. First is capacity management. We needed to take care of a large number of patients, and we needed to optimize our models of care and change them rapidly and quickly. And we wanted to do so in such a way that protected our patients and our providers from unnecessarily catching COVID and keeping our people as healthy as possible, which is the kind of philosophy around our containment efforts. So geographically cohorted patients, being really thoughtful about our PPE, which leads me into the conscientiousness part of this, which is we all faced limitations on PPE early on. So being thoughtful about how we entered rooms, how we took care of our patients, and then making sure that we were thoughtful about any model that we instituted, in particular around the sustainability of our providers and our team to be able to continue doing so. And then collaboration has been core and central to everything that we do, between working closely with our infectious disease specialists, our intensivists, many people that I never thought we would have such a close working relationship with. And then also thinking about our bigger and broader community, such as efforts like this, which is how do we share information. This just highlights one aspect of our approach to thinking about how we could flex in extreme ways. And I think at the university, we're very lucky to have a wide array of people, which include learners such as medical students, residents, fellows. In our division of hospital medicine, we are a large division at the university with over 100 people. We have a large presence of amazing advanced practice providers and physicians. And then we had a huge opportunity to partner with our outpatient providers, both generalists and specialists, to help come up with these kind of detailed and elaborate plans. But this slide, thanks to Adam Meyer, just shows that how we could grow in exponential ways. And on the extreme end of this, which is not on this slide, we could add technically even more providers to care for, more than 100 more patients. But what you see is that even with our learners, such as resident teams who have very strict guidelines on the number of patients they could see, there was still some wiggle room for them to flex up and still be within the ACGME rules. And then our teams, by harnessing the power of our APPs, utilizing independent visits where appropriate, and then bringing in our subspecialists and outpatient colleagues to help backfill the ward services so that our hospitalists could then flex over to the intensive care unit. All in all, we could flex to care for several hundred more patients, albeit in a very painful way. In order to accomplish this, we had a lot of different teams and groups and structures that helped us, I think, streamline the many different processes. So we have a highly skilled clinical operations team that met daily for the first several months of this and still continue to meet very frequently, met closely with infectious disease and critical care, and of course, hospital leadership with care management and nursing and many other people. And then we had a grassroots effort form with several of our frontline clinicians who love to read the most recent literature, and they would scour the literature to try to find the most up-to-date information and would put all of that information together in a document, which then fed over to our Pathways crew, which is essentially an electronic effort to build guidelines within our electronic health record. We have Epic. So our clinical care leadership team, which formed on its own, built the best practices as we would know it. Still today, we're evolving, rapidly, and then feeding that over so that we would have the best practices in our EHR for anybody. Even if you just picked up a ward team and you hadn't done it in a year, you would know how to take care of patients with COVID, and you would understand some of the basics of the ins and outs of inpatient care. We also had some of our hospitalists partner with the virtual health center, where our patients could get wearable devices to be monitored very closely at home, which I think was amazing very early on when we had a ton of patients in the hospital and still an unknown course of the disease, which we're bringing it back again in I think, bigger form today, just as we're seeing more and more patients. And then all these efforts then were studied and assessed through our data and analytics team. And so we have a core group of 3 people who would daily send reports out, and increasingly more and more people across our institution utilize those reports. So we know each day how many patients we have with COVID in our hospital, what is their readmission rate, what percent are getting transferred from the floor to the ICU. And then we use that information to then fine tune our guidelines. So our discharge criteria, et cetera, would be modified as needed if we found that we weren't seeing the outcomes that we thought we should be. And all of these efforts were in an effort to support our providers and ultimately our patients and their families. This is just an example of our order sets of sorts that we call pathways. So you can jump into this type of guideline of sorts in Epic, such that you can see what the most up-to-date information is across now our entire health system. And then as new information becomes available, then we update it. When you click on these, you can actually then have them convert over to orders. So it's a pretty efficient process. This is just an example of our treatment guidelines. We also have pathways for discharge readiness to help guide our clinicians and to standardize our care. I wanted to touch on this for just 5 seconds because I think it's a really interesting and emerging area of interest, I think, around COVID, which is point of care ultrasound in hospital medicine world. It was a hot topic before COVID, I think even more so now. And so we've instituted efforts to train our providers, in particular, who are on the COVID teams, to do point of care ultrasound. And increasingly, we plan to start utilizing more virtual mechanisms to educate and train our providers, with the hope in the next year to two, all of our providers are privileged and credentialed to be able to provide and make assessments with the point of care ultrasound. I think communication is key to all of this, with all of the many different places that information come from. And I think one of the lessons we learned early on is that we were getting 5, 10, 15 emails a day, it felt like, from different sources with the newest things, all in the spirit of sharing knowledge, but it was too much. And it was hard for people to really synthesize all of that. So we converted into a once a day daily email, and everything was routed through our clinical operations team to help minimize the number of communications and make it as high impact as possible. We would have daily, at times, meetings with our frontline providers who were providing the care, structured email communications, as I mentioned before, and then weekly town halls with whatever topic or updates were pertinent to the time. The last thing I wanted to just highlight, or second to last, is something called the Home Run Research Network. It's a hospital medicine research network. And historically, it has not focused on COVID, but has shifted focus on this over the past several months. And hospital medicine groups across the country are now contributing to the information sharing. I've put the website here because I think it provides a lot of helpful insights. So there are core groups working on thromboembolism and anticoagulation, discharge criteria, workforce planning, and you see the many other tiles. Anybody can go in, get an account, and then see the most up-to-date work that we have been doing. So I'm a part of the workforce planning group. And so you can see here's the page that everybody can get to. If you want to see the core questions that we asked, you just have to get a login. But we hope to help our institutions across the country with the most recent information. We do a lot of surveying, and we're now starting to try to understand which practices result in the best outcomes. So those are some of our next steps. What we did find in the surveys to date, though, I think is interesting, at least from a hospitalist perspective, is that I've spent, I think, a greater part of my career trying to understand what are the factors to implement geography in our hospitals. And prior to COVID, we had done a rather large survey of institutions, and it was a minority that could actually do it well. But what we found in COVID, which is when providers are committed and the institutions are, we saw in this cohort that we surveyed, 89% of them were actually able to geographically cohort patients. So I think the secret sauce there is provider willingness plus institutional willingness equals geographic cohorting. We saw a lot of utilization of modified inpatient visits, in particular with virtual visits. And then a lot of adaptations around census, with some places increasing their census on their hospitalist teams and others decreasing, which I think is interesting based on the literature that we've seen so far in my field, which is as you increase the census in traditional ways of caring for patients, it actually increases your length of stay. And so our team at the University of Colorado, as we have been deploying independent APP visits and essentially exponentially allowing us to see more patients, we're really excited to see how those outcomes such as length of stay are impacted. And then lastly, I think the big question that's on everybody's minds is how do we support our people? I think we were all stressed and energized the first go round. And then following that, when we actually had a lull in our patients, at least in the Denver area, we had the financial stressors of our institutions and all the troubles that I think many of our institutions face. And then now we're back to a surge again. And so I think mentally people haven't had the opportunity to rest. And I think that's a big challenge as we continue to go forward with this. We spent a great deal of efforts doing both surveys and then focus group support for our team members. And what we've heard loud and clear, at least a couple of themes, are that people are very stressed, in particular around caregiving, and that may be children or elder care. The school situation, I think, is a very big stressor with the uncertainty around that. I think people are hesitant around their careers and the advancement of their careers. People expressed a hesitancy to want to take on new opportunities with all the stressors that are happening. And so there's a huge effort within our division and our institution to really address this. One aspect has already in part been addressed by partnering with a third-party vendor to help with access to caregiving resources. And so there's many more efforts around this, but I think it's an important thing to keep front and center. And that's it. Thank you for your time.
Marisha, thank you so much. That was really interesting. And so our next presenter is Dr. Didi Mancini, and she is the Chief of Hospital Medicine and also an Associate Professor of Medicine. And she's at Denver Health. So she'll discuss surge planning from a safety net hospital standpoint. And I'd just like to also add, again, if you have questions, feel free to put them in the chat, or you're welcome to save them for the end of the presentation. Okay, Didi, you're on.
Hi there. Victoria's going to advance my slides for me. Thanks for having me this morning. It's been fun to hear Marisha's experience. Denver Health is significantly smaller than University, and I can say our operational resources were definitely different than what they experienced at the U. I want to start with talking about communication. I think Sarah experienced some of this with me at Denver Health, but we learned very, very quickly how paramount communication was in us activating and responding to the surge itself when it first came around. Denver Health did a couple of things. They created an institutional command center, which had all of our executives and then leadership within different departments such as infectious disease, et cetera, actually physically co-located down in the basement of our hospital when we were really in the thick of things. And so that was incredibly useful for us because it allowed all of the different division chiefs to have access and an opportunity to get to the institution and share quickly on a real-time loop what we needed and what we were seeing out on the front line. From that communication area, then everything was split up among the division chiefs. And what we found quickly is that we really needed to work together and communicate. I started probably within the first 5 or 6 days receiving upwards of 30 emails an hour, asking questions, offering help, needing information. And so within my division, which has 56 providers, essentially created what we called the hive mind. It was a group of people interested in actively collecting information for me, and then essentially giving me the most concentrated concepts of the day that needed to be addressed from my clinical team. And then I was able to take those hive thoughts straight to command early in the morning so that we could change things real time on the clinical floors. I think it was good, particularly for me, because it insulated me a little bit from all the communication that was happening amongst all the providers. And it allowed a clear conduit for my providers to get information to the institution and see real-time responses within even a clinical day. So I think localizing your communication pathways is going to be key as you respond to things like this. One of the things that I did is I started sending out a daily communication to my entire team every morning. Once we ran the numbers and knew what was happening, I would have collected the hive ideas and would be able to essentially give updated thoughts and plans strategically on what we were going to do for the clinical day in response to what we had seen previously. I think it was helpful. At any given time, about half of my team is in the hospital during the day and the other half are home. It allowed the people who were at home to stay real-time updated on what was happening. They were concise communications. And allowed them to sort of stay up to date even if they weren't on the clinical workforce for that day. I think too, it kept everyone feeling a bit connected, which during the first surge, I think the emotion and the fear associated with what was going on was really draining for people. And so having connection and access to information, I think was really, really important. I can say we are surging again at Denver Health right now. We've hit numbers as of this morning that are as high as some of our highest numbers in June. And again, I've restarted these daily communications. And I think that has been a very important part of sort of the workflow for my team. In addition to us sort of responding, we, in comment to Dr. Medit's question earlier about how do we kind of keep people separated and safe while they're practicing, the intensive care unit team, myself, and our division of just general medicine realized quickly we were going to have to work together to help support the strategic plan of expansion at Denver Health. And one of the things we realized quickly was that we needed to separate the COVID and non-COVID populations, both on the hospital medicine floors as well as in the ICUs. And so early on, retrofitted a lot of rooms at Denver Health to deal with what we anticipated being the ICU surge, and then separated our towers. So we had one tower that was essentially a COVID tower, and our other tower for general medicine was intended for patients that were surveilled negative for COVID. And that separation geographically was really important for a few reasons. One, it allowed me to recruit some help from outpatient doctors into the hospital and give them some confidence that they weren't going to be mixing in the COVID population, which was a group of patients at the time they didn't have experience with, and I think we're kind of nervous to take care of. Two, it allowed the COVID providers to be in one geographic space and have some proximity and access to each other while still staying essentially in a clean area. And then we had assigned workrooms for our COVID providers so that they could have dedicated spaces that they could see patients and then find some seclusion to get work and eat their lunches, et cetera. We retrofitted those rooms. So at any point in time, we really only had 4 or 5 providers in a room that would normally have 12 providers in them with computers that were spaced. So it allowed them some snacking time, some work time that was separate. And so particularly during the first surge, that's how we sort of dealt with keeping our staff localized and separated. What we additionally did is realizing quickly that the ICU, hospital medicine, were going to need to collaborate. The ICU was expecting to have humongous numbers that our overall pulmonary crit team could not deal with. We ended up training up 15 of the 56 providers we have in hospital medicine to provide intensive care work. And what we did is started multidisciplinary rounds that ultimately became institutional multidisciplinary rounds every morning so that we could run actively all the cases on the medical floors that had COVID that we were concerned potentially were going to require transfer to the ICU. It allowed my team to kind of give the pulmonary team a heads up on people that were beginning to bubble so that we could facilitate pulmonary consults more quickly and expedite transfer if it needed to happen. Additionally, we were able to hear about the cases in the ICU, how things were progressing, so that the hospital medicine teams could see the entire spectrum of care, from bringing them in the door to what was happening after they were in the ICU for a week or two. And then additionally get heads up on patients that had been stabilized and were safe for disposition out of the ICU back to the medical floor. These rounds started as just hospital medicine and the intensive care unit. At their full fruition, it ended up involving additionally our surgical teams, our respiratory therapists, and some of our executive staff, as well as our infectious disease colleagues and our palliative care team, so that we could quickly get consults and care coordinated and collaborated in the mornings and deployed for the rest of the day. I would say this had never happened at Denver Health before. It was really quite moving to see all of these providers in a room together, engaged, helping each other, making recommendations, and expediting care. It was also a comfort, I think, for everyone to be together, socially distanced in a huge conference room, but be able to share cases and concerns in a more casual format. And frankly, see the physical power of the team that we had deployed for our COVID care. The other piece I think that was really great is it allowed the intensivists and the surgeons that were involved in, some of the advanced care of patients who were some of our sickest, to also hear the positive outcomes when hospital medicine was effectively able to discharge patients that had been hospitalized for 30, 40 days. And we could tell the stories of watching them walk out with their families, et cetera. So I think there was an important sort of emotional piece to these daily rounds that I think were quite powerful. So I think particularly localizing communication, making really clear pathways for communication, and making sure that your specific teams have ways to access you that aren't going to overwhelm you, and additionally allow quick feedback so that people know they're being heard and responded to, is absolutely integral as you're dealing with surge planning. Victoria, next slide. So as I sort of alluded to, we did end up mobilizing a lot of help to allow hospital medicine to extend its care into the intensive care unit. What we did early on by separating our two towers is we asked our GIM and family medicine colleagues, as well as our subspecialists. We had several gastroenterologists and other subspecialists such as infectious disease coming in, and they took over our teaching teams up in the non-COVID tower where they had good support from the residents, but were able to free up. At one point, I had all 6 of my hospital medicine providers that should be up on the floor, liberated and down doing work in the ICUs or on just basic hospital medicine teams. I think having the tower separated was key. We created essentially one person that was responsible for all communication with the outpatient docs coming in. I think at our peak, we ultimately ended up having 40 volunteers that circulated through the course of those first few months and up on the floors working with our house staff. Again, they did not have exposure to COVID patients. We tried to keep them protected and have them do work that they were more comfortable doing away from the COVID population. And that allowed us to free up that group of docs of ours to do ICU level care. I feel like that worked rather smoothly in the first surge. And the reason it did is because outpatient clinics obviously closed down. As we head into the second surge, we're finding it a lot more difficult to activate that outpatient team because they're all running at 100% capacity right now in their clinics. And so we're dealing with some different hurdles in the second surge than we were seeing in the first. Ideally, we're hoping, again, to activate some of those teams in maybe a more concentrated form so that I can free up my docs again to provide ICU level care. We're going to change the format and the way we support the ICU because this surge, we're actually seeing record-setting highs in non-COVID volumes. So we came through COVID, hit our peaks, came down, and as soon as the COVID numbers dropped, our non-COVID numbers surged. We started seeing 25% higher volumes than we've ever seen historically. We've had to open additional teams in hospital medicine just to deal with the non-COVID numbers, which have stayed high. So we're going to be changing the way we support the ICU because we're still seeing those very high non-COVID numbers with the COVID surging again. But again, I think keeping things geographically separated is going to be really important for us. And then activating people in a way that is comfortable for their practice pattern while freeing up staff for us is going to be sort of the tenement of the way we proceed forward. Victoria. So this slide matters kind of most to me. As Marisha alluded, this has been an incredibly hard experience for the inpatient teams, as well as the subspecialists, and frankly, for the outpatient docs as well. We did a few things at Denver Health that I think helped, although I will say my teams are rather exhausted with the COVID surge and just the anticipation and the fear that went into care early on during the pandemic. I think people were frankly exhausted as our COVID numbers dropped. And as I said previously, our non-COVID numbers surged so high that we were having to do additional work we weren't used to. So my teams really have not had any rest since February. And here we are heading into another surge. We quickly organized groups and collaborated with RISE, which is a program known nationally to provide support to medical providers in their care areas. And so we collaborated with RISE in our psychiatry department to essentially deploy team meetings where my team confidentially could sit down and talk together about the things that they were experiencing during the pandemic. And we had several of these through the course of the first pandemic and have more anticipated to come. I can say this was a really powerful tool. I was able to attend to all of them, and it was important, I think, for people to have the opportunity to be in a safe space, a confidential safe space with their teammates and only their teammates. We kept it isolated just to the hospital medicine team where they could talk about every part of the pandemic that was hard. We had several of these through the first surge, and I can say the themes changed from the beginning to as when the surge was resolving. But people were really struggling. They were struggling with being a provider and being on the front line, and the fear that early on they went through trying to keep themselves safe and feel confident that they weren't going to get sick from choosing to provide this care. Those same people are struggling at home to help support their kids who are home, their spouses, some of whom couldn't work. There were stressors really across the spectrum for everyone. And then additionally, a lot of our providers were a bit scorned socially. People didn't want to see them, didn't want to interact with them. We had schools asking some of my providers' children to not attend because they felt that those kids were too high risk. So it was emotionally a really challenging time. I think it was powerful for my team to speak to each other and share some of those vulnerable moments and places. I can say it certainly tightened our emotional team dynamic. Doing so, and it has been really powerful for the people who have attended more than one of them to really see how things are changing and feel safe to say, this just feels bad, I don't have anything to look forward to, and I'm struggling. It also has allowed me to really hear places where I think if we can provide support to our clinical providers to be able to do so. So I would really encourage you in your institutions to take the time to allow people to really speak and just verbalize what they're experiencing. We did some qualitative work as well during the first surge, and I can say one of the biggest themes that echoed through people's struggle was just the overall uncertainty, not just of the clinical care they were providing, but uncertainty just in the world and in their lives. And that continues to be true as I work with my team and hear what they need. The little things that we're able to control and allow them to predict, I think are important. We've changed the way we're deploying our schedules so that our team knows at least this far in advance what they're going to be doing. We're sticking to certain caps so that they know when they come into work that they're not going to have more than a certain number of patients. And although I think those are little things, I think it does help stabilize some of the uncertainty of providing care at a time like this. One of the other things that I started quickly during the pandemic were something we called COVID Warrior Awards. And so every Friday, I would just pick several providers within my team and highlight some of the extraordinary things that they were doing so that, one, they were acknowledged, and two, so they knew they were being seen, not just by me, but by the institution and by their team. And so usually accompanied these with little gifts or treats or whatever, but it allowed every week for people to look forward to just celebrating ourselves. I plan to start those again this Friday. I think this was huge. I think it was huge for my team to have some positivity and some things to look forward at the end of a long week. And people really want to celebrate each other. So I think creating the opportunity or the forum to create rapid cycle acknowledgement, I think is really important. And then I probably baked 200 dozen cookies through the course of this pandemic. I'm not sure that this is probably a validated way to support your team, but a little sugar and a little treat at the end of a long clinical day seem to go really far. Next slide, Victoria. So in summary for me, I think the things I've quickly thought about this week as we've started searching again is the communication, making sure that my team knows that I'm on things, reactivating my hive so that I'm getting information from my team, and making sure that I have a clear pathway to the institution. I would say of all the things, this is probably one of the most important. I don't know, I see where some people are calling in from. Many probably don't have operational systems in place like universities. So you're going to have to grow these a little bit on your own, but making sure that you have access and direct communication with key players is really important. Collaborations, I can't say enough about this. I think being able to connect with your colleagues, the subspecialists that you need, palliative care, infectious disease, pulmonary critical care, and bringing those people, if not physically together, at least together in a format that is predictable and efficient is really important. And I can tell you some of these relationships have lasted. It's been very fun. The head of trauma and surgery are like buds of mine now, having gone through this. And so I think building those relationships is really key, not just for your institution, but for the teams that you're leading. And then just reflect on your teams, reflect on their strengths and their accomplishments, and try to shine that back on them. I think in a time where people have so little to look forward to, and we're asking 150% of them, making sure that they know that they're acknowledged and seen, I think is really important. That's what I have for you. Happy for any questions.
Dee Dee, thank you so much. That's so terrific. And so with the remaining time, I would like to introduce two other panelists. So we have Mark Meyer, who's the Director of Pharmacy Services and Infection Control at Southwest Health System, and Barry Hummaker, who is a surgeon and Chief Medical Officer at Vail Health. And I would ask if either of them have any remarks they would like to make briefly in response to any of the questions or any of the discussion thus far. And then I'll open it up to general discussion. So Mark, do you want to go first?
I think the discussion we've seen this morning is kind of a trend probably around the country where hospitals have kind of bonded together and really improved how they can communicate and get along and really look at how they can expand how to take care of patients. And I think what we've learned, if we've learned nothing from COVID, that's very important for us.
And Barry?
Yes, can you hear me?
Yep. Sure.
So I just wanted to cover a couple of things that we did at Vail Health. we'll just call the first one securing the perimeter. We have a very close relationship with all of our primary care providers. So we were able to very rapidly assist them with setting up respiratory ill clinic, in addition to them maintaining their normal outpatient flow, which kept, COVID patients that didn't need to be in the emergency department out of the emergency department and could be cared for by their primary care. In addition, we were able to rapidly set up a drive up outpatient testing center. So we had multiple places throughout the valley where one could receive care without coming to the emergency department. And then the other piece in terms of communication, which I agree with everyone is critical, with the way we set up our incident command, it went from sort of a report out to using that as a rapid decision-making tool where someone could bring up an issue, and typically we could either resolve the issue or figure out what small group needed to huddle to deal with, equipment, PPE, additional personnel, or coming up with some policies to guide us. So those were two of our keys to be successful. And then the third, in terms of the fear, we had our executive team out essentially throughout the day and at times of the night, checking in with all of our teams, seeing what they needed, making sure they felt supported. And that's it.
Terrific. Thank you. Those are 2 points that hadn't come up yet. And so with that, I have a few questions, and but first I'd like to open it up. We haven't had many questions come in the chat yet, but if anyone has any questions that they would like to offer to the group, and I would encourage you all to turn on your cameras, and we can put this in gallery view and see who's here. And so I'll just give it a second. And one question was, what has been early experience with outpatient providers assisting with hospital work? And what are the key aspects of doing this well and providing adequate support? And I should mention that, I was asked if at our institution, specialists have been asked to do inpatient care again. And I know that GIM has already experienced a call for inpatient help, but to Dee Dee's point that clinics are not closed now, I think this is a whole new challenge. So I don't know if anyone has any comments about pulling in outpatient providers to do inpatient work.
I mean, I can comment on what we experienced at Denver Health. I think in the first surge, when we first proposed the idea of bringing our outpatient colleagues in, many of them were really nervous about being on the COVID floors. And so it was clear really quickly that we needed to create that clinical separation so that they knew they weren't going to be exposed. I don't know if that would be the experience everywhere, but I think you really do need to tap into the people you're asking and sort out what they're comfortable with and make sure that you're deploying them in care spaces that they feel safe. Otherwise, I don't think you're going to get great responses on people coming in and helping. I think it was additionally lucky for us that we were deploying our outpatient colleagues on the resident teams, so they had a bit of a buffer and a workforce underneath them. And as we joked all the time, they had the residents supervising their work because many of them hadn't been on the general wards in a long time, dusting off their stethoscopes. So, I think you really have to be sensitive to what your outpatient colleagues are comfortable doing if you're going to deploy them.
And I think at university, we had well over 100 volunteers, and actually I'm going to call in Casey, who helped lead the effort to kind of expand on our efforts.
Yeah, so when we were making the effort to solicit outpatient providers for inpatient work, we had a few steps to it. So first we did a poll just to see what kind of volunteers we would get. And we also asked people what kinds of shifts they'd be willing to do. So whether like day shifts on resident services, independent day shifts, and then swing or night and cross cover shifts. So we organized all of that. We also asked them about how far out of outpatient work they were and what their current experience was. So people who were just, you know, had just completed residency and just were like, had just started in the outpatient realm versus the person who'd been 20 years in endocrinology or something like that. So then we created a tiered list, essentially, of people who could transition the easiest from outpatient to inpatient. And we organized that based on which shifts they would be able to do. And then finally, we created a really, actually, in partnership with our outpatient colleagues, a really robust, essentially like basics of inpatient medicine guide. I think this thing ended up being about 100 pages long, but it had a combination of just some of the common medicine things like CTE prophylaxis and like, you know, certain like components of hospital care. And then it also had systems teaching in that as far as like Epic and, you know, here's how you do the inpatient charting. And we also had some instructional videos on that as well. And we did 2 grand rounds. So one of those was systems based and one of those was essentially both of those were kind of this like combination of intro back into inpatient medicine, both from here's operationally just how it works, like here's literally where you'll show up and where you'll get your list and that kind of thing. And then some of those kind of like medicine basics, so some of those updates.
And Casey, that I think that the operational details would be more specific to your institution, but the inpatient medicine bread and butter, like here's what we do for, you know, DVT prophylaxis these days in case you haven't been on the wards in 10 years. Is that available?
I don't know if we've made it publicly available, but I don't know of any reason that we like, you know, wouldn't be able to. We had it, I mean, we literally embedded it in our EMR so that all of our providers could access that. But I don't know that it's been distributed outside of our institution. But like I said, I don't know if there would be any limitations to that aside from, I mean, the other people that kind of helped that put that together because it was like a several person effort.
Yeah, I think it, you know, could be very useful. We could let this group know, you know, if that kind of a how-to guide to inpatient care is available.
Yeah, we could definitely look into that.
Thanks. And I just wanted to mention also while I'm thinking about it, our first 2 echo sessions for those who didn't make it were about current therapeutics recommended for COVID treatment. And so we had a quick review of remdesivir, dexamethasone, and convalescent plasma in session 1. And then the session 2 was about pulmonary management, pulmonary pathophysiology and management. And so both of those are recorded and available on the website for anyone who's interested in those topics and wants to watch them or see the slides. But with that, any other questions that anyone wants to offer? And I do see one from Erica. Erica, do you want to unmute and ask your question?
Hi, everybody. So I am a hospitalist and also the infection prevention physician in charge of COVID here in Salida, Colorado, which is a small critical access hospital. We are seeing a surge here. We don't really have any support. We don't have infectious disease. We don't have pulmonary critical care. We don't have access to, we're a self-standing hospital. But I would like to be able to have some resources for questions, especially in regards to when we have a situation with a employee who, like Amy Meditz was talking about, doesn't wear their mask when they're having lunch. And then we have, a couple employees have positive tests. And what do we do with our patients that they were exposed to, et cetera? I think, like that. The other is supporting the schools and their their testing and what kind of testing will they allow. Public Health has changed their testing format and we have bought equipment to support them, but now they've changed their format. So I just would like to be able to have somebody to kind of run some of these things past, because as you know, being a sole person trying to run this in a small hospital is exhausting.
Yeah, that sounds exhausting. And as we go into this next surge, certainly relevant to have those protocols in place. I don't know if any of our presenters or anyone else on the group has any recommendations for, who is fielding questions coming from smaller communities without the resources of our institutions.
Hey, Sarah, this is Amy Meditz, and Erica and I have spoken in the past, and I'm certainly, willing to take any calls that she has. This is a critical time, no formal relationship has to be made. We're still happy to support the hospital in Salida, and I'm sure many people out there are as well. It's just she already has my phone number, so.
Thanks, Amy. It's really appreciated.
Erica, this
I
is
know you guys
Dee.
are all so busy and burdened with such higher numbers than we are, but it is nice to have that support when
Yeah. Don't worry. Yeah. Don't worry about wearing us out. We're in this for the long haul, and we really want to help the community the best we can.
Thank you.
And Amy Meditz has my cell phone number, and she can forward it to you so I can help with anything operational.
Well, thank you. I do see that there's Silverthorne on and, other small hospitals, but I think they have bigger connections to like St. A's and stuff. So thank you so much.
I would also encourage, everyone to continue to tune into the Echo, because we can bring up these individual questions here while you have a panel of experts, infectious disease, hospital medicine, infection prevention. It doesn't have to be on topic. You're welcome to bring those questions to the panel every 2 weeks as well. So we're here for you as a group. And there's one other thing I was going to say about that, but I forget. Oh wait, I know what it was. We are going to do an upcoming session on infection prevention in the hospital setting. It's been such a moving target with variable recommendations. So we'll get the latest on that at an upcoming session as well, which will hopefully be useful. A couple last minute things. We don't really have much time, but in terms of if anyone had any comments about bed reassignment, staff reassignment planning, and also things that they did the first surge that they'll be doing differently this surge.
I think for our critical access hospital, we had our first surge was back in June, and we were having about 20% of our patients in the house with COVID at that time. Obviously, flying out the critically ill when we can. We learned right away that we wanted a COVID unit, so we actually moved our OB section upstairs to our old hospital, and moved those patients into that area, which we can house about 15 patients if we have to. And we also early on, increased our CMS licensure to 60 beds, realizing that we could handle 60 patients that did not require, ventilators. We do have 12 ventilators and do have a plan to manage that. We do have a pulmonologist that's going to help us with that. So, we've been trying to train staff that don't normally handle patients on vents to do that in case we need that. That's been a challenge for us as far as education. And we also early on were able to get in-house PCR COVID testing. So we've been running, we run a COVID line every day. We've done about 5,000 tests through our hospital so far, which is a lot for a small hospital. And really working with that. We also shifted to, in our clinic, we have a 2-story medical office building attached, and where we house about 90% of the providers in the area, to telehealth, and shifted all the patients with symptoms to our walk-in area, actually see them outside in the COVID line, and try not to expose anybody. And if they need care, we shift them into our ICU then to try to take the burden off, our shift care into the ED, try to get the burden off the ED, because it can get rather busy in our ED here. And because we are close proximity to the Navajo Nation, the Ute, Mountain Ute Nation, and we see a lot of overflow spillage from Utah, Arizona, and New Mexico, and we all know the problems that they've had in this part of the state. And we try to fly people out as best we can. But we do feel that we could, if we had to, medium level patients, we could keep 90 patients here if we had to. So that's kind of where we're leaning towards this second wave, because right now, through the summer, we've seen, 1 to 5 cases a week. Right now, since the 1st of October, we're seeing 20 positives a week. And so it's really, really picked up since school started. And we also have to deal with a large population of people that don't believe in masks and social distancing and things like that, which compounds the problems in our areas.
Thanks, Mark. Yeah, it's fascinating to think of what's put us in better shape, like the fact that we have testing capabilities now compared to the first time, and what's going to be, whole new challenges. And there was one last question about environmental controls for outpatient care clinics and emergency and urgent cares, if anyone had any quick thoughts on that. I think that will be something we will definitely kind of look into and get back to you. Aaron, who asked the question, and we did get some comments about offloading emergency departments, but in terms of improving air circulation and infection prevention techniques that way, I think that's really an area for further discussion. So with that, I thank you all very much, and I'll turn it briefly back over to Victoria.
Thank you, and thank you to Sarah and all of our presenters and panelists today, and for all of you who were willing to unmute and come on camera. Again, we really appreciate that. That makes us much more lively and engaging for all of us. I did put in the survey into the chat. So again, please take that. That helps us determine future topics. As Sarah mentioned, we try to be really responsive to what you all want to hear about. And you can also, it gives you a chance to let us know any other comments. So you'll see that link in there, and then you'll see my email and Caroline's email. Please reach out to us if you have any questions, or if you want to submit any future topics, or if you want to present a case, you're welcome to email either of us there as well. But with that, I will go ahead and say you are all welcome to head out. I will put up one poll before you leave if you want to answer that. We're just curious if you have a preferred time for these sessions. So we have it currently in the morning, 7:30 Mountain Time, but would you prefer a lunch hour or, a more evening option? So I'll leave that up for just a few moments, but thank you all for joining today, and we look forward to seeing you in 2 weeks when we talk about post-COVID syndrome.